afternoon. I am going to talk about sonographic evaluation of the umbilical cord and cord anomalies. Less talk subject. I have chosen a pink color because Jaipur is a pink city. Why umbilical cord is important? Umbilical cord is a lifeline, narrow tube-like structure, connects the developing baby to the placenta, and it is known as a supply line also because it supplies nutrients and oxygen to the baby and removes waste product. The role of sonography is important. Earlier it was thought just count the number of vessels and everything is over. But now it's playing an important role in hemodynamics. It is actively involved in identifying important processes like fetal growth restriction, preeclampsia, diabetes, and chromosomal defect and genetic syndrome. The morphology of the cord is 50 to 60 centimeters long, usually covered by amniotic epithelium. The vessel is embedded in the Wharton's jelly. The characteristic feature of an umbilical cord is its helical course with the arteries round the vein. Here is a Wharton's jelly. You see the cord, artery and vein and Wharton's jelly marked by arrow. It's a gel-like structure. It's no proper vasculature, but it helps. It gives flexibility and strength to cord as well as it transfers water and metabolites between the amniotic fluid and umbilical cord vessel. Bidirectional transfer of water and metabolites. So it is very important and it helps in the remodeling and embryogenesis. Here is a picture you already seen Wharton's jelly. Then structure is very dynamic and influenced by a number of factors, including gestational age. The cord will be different at 13 weeks, the cord will be different at 30 weeks. The amount of amniotic fluid, composition, and fetal movements. As the fetus moves, it pulls the cord along and it helps in the lengthening of the cord. Then feto-placental hemodynamics, maternal complication during pregnancy. It is better to do a cross-sectional view because you can have both vessel and you can assess the Wharton's jelly. The length of the cord usually begins to form at 5 weeks. At the length increase in the length is 28 weeks until it reaches the 55 and 60 centimeters. Here is the picture early pregnancy where the CRL is equal to the cord length. It is up to 12 weeks. The cord length is equal to the length of the baby. Then abnormal cord length, if it is less than 35 centimeter, it is short cord and it is associated mainly to a fetal distress, placental abruption, prolonged labor, and associated with anomalies also. The long cord is more than 70 to 80 centimeters, and you know when the cord is too long, it can coil around neck, can prolapse, and can be compressed. The diameter, the umbilical artery, is smaller than vein, but the diameter increases up to 32 weeks. We have seen the length is maximum is achieved up to 28 weeks, but the diameter increases up to 32 weeks. There is a significant relationship between cord diameter and fetal biometry. There can be a lean cord and large cord, patla cord and mota cord. If the sonography cross-sectional area shows below 10 percentile gestational age, it is lean cord. Here is the picture. It can be associated with oligohydramnios, less amniotic fluid, fetal distress, SGA fetus, meconium stained amniotic fluid, and adverse pregnancy outcome result may. Then the large cord is above 90 percentile of the gestational age, associated with focal lesion also. Can you see a large cord with a focal mass, tumor, cyst, and you can see gestational diabetes and macrosomia. The umbilical cord coiling. The normal coil of the umbilical cord looks like a telephone cord. You see the coiling of the telephone cord, it is normal coiling. If it is coiling more than that, it is hypercoiled, and it is called, if coiling is less than that, there is a hypocoil. But there is a definitely a coiling index is there. One has to, it should, one coil every 5 centimeters of length. So the normal length of the cord usually get 40 coils. Then there is 10 percentile hypo, 90 percentile ever hypercoil. Then there can be atypical coiling also, bizarre pattern. Here is the picture, you are seeing an hypercoiled umbilical cord, and this is a hypocoiled cord. You see the hypocoiled cord is, here is a smooth surface, flat surface, decrease, it leads into the decreased amount of nutrients sent to the fetus, IUGR and other problems. Hypocoiling is also associated with fetal anomalies. Then this is a fetal normal cord insertion. This can be central and paracentral, the normal cord insertion. Here are the pictures with the normal cord insertions. Then there can be abnormal cord insertions. It can be a marginal, furcate, volumentous, and vasa previa. Furcate insertion, the vessel separate from the cord before insertion. The marginal cord insertion is at the margin of placenta. Cord can be pulled out during delivery. And then volumentous insertion is, it is into the membrane. You see in this picture, it is inserted into the membrane. The vessel is unprotected, and it again then it crosses over and the inserts before the placental plate. Here you are seeing a cord insertion into the membrane. This is a picture showing a marginal cord insertion. Then vasa previa. This is also very, very important. When one or more vessels from the cord or placenta can cross the cervix, they are unprotected, they might tear, they might get compressed, bleed, and must diagnose prenatally, otherwise the mortality can be 33 to 100%. It is associated with increased risk of, it is associated mostly with the vasa previa, placenta previa and volumentous insertion. Here is a picture, you are seeing a volumentous cord, unprotected cord with vasa previa. This is a serious situation. Then what is a normal physiological herniation of bowel? It is the bowel herniates into the cord. It is a normal development sequence. You get into 6 to 8 weeks and it herniates back into the cord by 12 weeks. But herniation gets reversed by 12 weeks. Sometimes the stomach and other contents are seen. Liver is seen in the early herniation, which is not normal. The omphalocele is a midline defect and herniation of, it looks like a central mass protruding from the anti-abdominal wall, and it is usually contains the small intestine and liver. There can be other organs also can protrude like large intestine, bladder, stomach and spleen. Here is a picture we are seeing. This is the liver herniating into the cord, and you can very well see the umbilical arteries, umbilical vessel traversing through. The stomach is trying to protrude in. Then there are umbilical cord cysts. They are important. They can be single, there can be multiple. An umbilical cord cyst, you can't differentiate what is a true cyst, what is a false cyst. They are multiple. Usually they should disappear by 12 weeks, but if they persist, it may result into poor fetal outcome and associated anomalies. Here in the picture, we see an umbilical cord. This is a cyst, and you can have to differentiate sometime, but it's very easy. Yolk sac, which is seen outside the amnion, it is more echogenic wall. The normal vessel of the cord, we all know Mickey Mouse appearance, you are quite familiar to it. The 2 artery and 1 vein. You can see in the longitudinal cross sectional, but you can see also along the lateral wall of the bladder, you are seeing the 2 vessels. Then there are arterial anastomosis. It's much less discussed, but it is anastomosis between interarterial anastomosis. It equalizes the pressure between the placental lobes, and it is seen in 95% of the normal placenta. Can you see the hiatal anastomosis? It is an intra-arterial communication. Then there is a two-vessel cord. Two-vessel cord SUA. SUA is very important. It is seen in 1% of the single tone and 5% in the multiple pregnancy. The left umbilical artery is absent, either it is not developed or gets atrophied. You can detect it by cross-sectional, longitudinal, lateral bilateral. Here is the picture showing you the single umbilical artery. There is no umbilical artery here. It may become, it's a single umbilical artery because it has to take the function of two. It becomes large, it reaches a greater, it may be 4 mm up to 20 to 36 weeks, and even it can be equivalent to the veins diameter. The ICA identification, SUA is poor, sometimes when the liquor is less, the card is small and multiple pregnancy. Then comes the isolated SUA. SUA can be associated with chromosomal abnormality and then can be an isolated SUA. The isolated SUA is not much of any importance. Only thing when you detect an SUA, you have to do an anomaly, look for anomaly, do an anomaly scan. And if you find any chromosomal abnormalities, other features associated, you can do amniocentesis, fetal echo, and even the postnatal assessment. These are the anomalies associated with SUA. There is a huge list of it. It is not possible to enumerate all of them. There are huge lists. Then comes the discordant umbilical artery. The one artery is here. You will see a picture when the one artery is smaller, and this is important because if you do a casual scanning, you miss this discordant artery and you may label it an SUA, but discordant artery is there. The small arteries are there. They are associated with placental alterations, absence of hiatal anastomosis, and abnormal placental insertions. The importance of it is you must pick up a discordant artery so you avoid a lot of problems. The umbilical vein, this is a normal umbilical vein curving away from